So hi, I want to say good morning. It's Eileen Bird, the Executive Director here with To Life. And I want to welcome everyone to the first of our Women's Health Conference series talks. We're very excited to be launching this series. And so we will be starting in just a moment or two. As you see up on your screen, Dr. Pesek is with us and has has her whole slide up. And so just a couple of housekeeping things as we get our morning going here. You have joined on our webinar in a mute status, and so we would welcome questions you have. We will produce the talk, and Dr. Pesek will talk, and then we will do a nice Q&A. Following that, you can put your questions into the Q&A box at any time, and we will monitor those throughout the formal remarks and then address questions. And so as you start to think about things before you lose sight of it in your head, please just punch it in there. And then I'm sorry, I'm just not focusing today a little bit. And so as you see, there's several people that are going to be speaking this morning. And what I'd like to do first is just to say thank you for the people who have sponsored this program. And I know that we are still in a virtual environment, but the education programs of To Life have been supported by several sponsors, including the New York State Department of Health. And we've had a grant from them for a number of years and are very happy to represent their interests this morning, as well as the New York Oncology Hematology Organization, Fenimore Asset Management, CDPHP, and we have support from Women at Work through the Times Union program. And so, but for this morning, what I'd like to do is, as I mentioned, this is the first of 4 presentations that we will launch. We're going to continue to do them virtually this season with high hopes that we can move to an in-person format going into 2023, which would be very exciting. And so before we bring on Dr. Pesek, I'd like to introduce Rita Cox. Rita is the president of To Life and is joining us virtually this morning. And so we're happy to have you because you don't always have time to join on education programs. So yay. Welcome, Rita.
Thanks, Eileen. I have to say and actually isn't the right word, but I'm especially excited about this topic because this was not the way breast cancer was treated when I was going through it. And so I'm so happy to hear that this is a focus and de-escalating surgical treatment is a major concern. And you know, when you're going through it, you make the decisions that you make based upon the information that you have. And things progress. Thankfully, that those who follow you may have a different experience. So my hope is that with what we're going to learn today, and with the effort that Dr. Pesek and others are undergoing, I guess is the right word, that we'll see less surgery and other methods for treating breast cancer. So I'm very happy that everybody can be here this morning. I'm happy to be here. And thank you so much, Dr. Pesek, for being here.
Okay, thanks, Rita. I'm glad you're with us. And so I know that we're going to learn a bunch of new things. I have seen a peek at the slides. So now let me tell you about Dr. Pesek. And so I'm so excited that she's with us this morning. Dr. Pesek is a breast surgeon, and I know many of you have had experiences with Dr. Pesek, but she practices at St. Peter's Health Partners, where she has been seeing patients since 2015, which seems like an eternity ago, but probably not that long ago for Dr. Pesek. Dr. Pesek is a native of Western Pennsylvania. She attended college at the Johns Hopkins University, then continued with medical school at Penn State, completing her general surgical residency at the University of Vermont, one of my favorite places on earth, then had breast disease fellowship at the William and Infants Hospital of Rhode Island. In her free time, which I don't think she has a lot of, just as a general observation, she enjoys reading, hiking, and skiing. And so now I want to welcome Dr. Pesek, who will give you a little more insight and move into our presentation. Thank you.
Hi, good morning, everybody, and thank you for coming to listen to me talk. So we're going to talk a little bit today about the de-escalation of the surgical treatment of breast cancer. We're going to start off with talking about what the history of surgery for breast cancer was and how it both increased in the beginning and then began decreasing and why. We're going to talk about what's acceptable to do and not to do at this point in time. And we're going to talk about what further de-escalation is on the horizon, what things are being explored. So first off, we're going to talk about the development of the radical mastectomy. So way back in the 1800s, in the mid 1800s in London, there was a surgeon who noted when he would take out breast cancer that it would tend to recur at the margins of what he took out. So he hypothesized that the entire organ, meaning the entire breast, should be removed. And then in Germany, a surgeon took this a step further and felt that the breast and the pectoralis minor should be removed. And really what they were referring to was like a centrifugal theory, that breast cancer started in the middle and then spread outwards. And this was taken even further by a couple surgeons in the US, William Halsted and Willie Meyer, who decided to also remove the pectoralis major and muscle and also the regional lymph nodes. You can't talk about the history of breast cancer surgery without talking about William Stewart Halsted. And he was a gentleman who had some demons. He had a cocaine addiction, and to get a fresh start, he was recruited to the Johns Hopkins University Hospital. And that was where he developed his Halsted mastectomy, removing the whole breast, the major and minor, and the regional lymph nodes. And he presented upon this topic in the 1890s in a conference in New Orleans. And following that, this became the standard of care. Again, this is the whole breast, the muscle, the lymph nodes, and it left women fairly disfigured. And it was the standard of care for breast cancer surgery for the next 80 years. And people even tried to push it further, like the radical mastectomy became the ultra radical mastectomy. Not only were they doing what was involved with the radical mastectomy, but they would push it to remove parts of the ribs, parts of the sternum, clavicle, the internal mammary lymph nodes. And as you could figure, even imagine, this was really disfiguring and it could possibly defunctionalize like the arm, or patients would have other problems. One surgeon even stated that it was his duty to carry out as radical an operation as the anatomy would permit. But some people in the 1900s started challenging the radical mastectomy. A surgeon in 1920s London was combining local surgery, meaning lumpectomy, with radiation. A surgeon at the Cleveland Clinic started using a limited surgical approach, meaning the simple mastectomy, where he just removed the breast and nothing else. And they were finding that the survival rate seemed to be no different than those patients who were treated with the traditional radical mastectomy. But in order to prove that less surgery was just as good as more surgery, you had to compare patients head to head. You had to take similar groups of patients and either say, do a flip of the coin, and either they got a modified radical mastectomy or the Halsted procedure. And this was done in the NSABP VO4 study, which was headed by Bertie Fisher out of Pittsburgh. The study occurred in the early 1970s, and it compared a radical mastectomy with total mastectomy, and it compared it in two groups of patients, either those that were clinically node negative, meaning they had no palpable axillary lymph nodes, or those that were node positive. And in the group that was node negative, they either got a radical mastectomy, a total mastectomy, or a total mastectomy with radiation. And those who were node positive either got a radical mastectomy or a total mastectomy with radiation. And there was some considerations for the axillary surgery in this. So for the patients who were node negative, they didn't get upfront axillary surgery unless they were in the radical mastectomy arm. So they just got a total mastectomy or just got a total mastectomy with radiation. And in those clinically node negative patients who underwent radical mastectomy, 40% of them had positive lymph nodes. So assuming that all groups in the study are equal, that would let us think that patients who were having the total mastectomy alone or total mastectomy with radiation also had about 40% of their lymph nodes positive. But despite this, only about 19% of the patients who underwent total mastectomy without radiation, meaning they had no treatment whatsoever to their axilla, had an axillary recurrence. So the results of this study comparing the radical mastectomy with just a total mastectomy or total mastectomy with radiation, no matter what group they were in, and they were node negative, there was no difference in survival. And the same thing for the node positive patients, no difference in survival, what surgery they had. And there was no difference in distant recurrence. And this is comparing specifically the surgeries with node negative and also with node positive, but not comparing node negative to node positive patients. There was a lower risk of local recurrence in the patients who are node negative if they had radiation after their surgery. So therefore their axilla was being treated. And this lower risk of local recurrence was even lower than those who were getting the radical mastectomy. And there was no difference in local recurrence in the patients who had clinically positive lymph nodes. So after this study, it was considered the least surgery that was acceptable for patients with smaller tumors was the modified radical mastectomy, removing the breast and levels 1 and 2 of the axillary lymph nodes. And the reason for removing the lymph nodes was, again, in the patients that were clinically node negative, 40% of them did have axillary metastases if they went in the group that had the radical mastectomy. So the next step was to compare lumpectomy with mastectomy. This was done in the NSABP B06 study. And it happened in the late 70s and early 80s. And this is the most popular of the studies, famous studies comparing lumpectomy and mastectomy. There were several others as well. But this one in particular compared mastectomy with lumpectomy or lumpectomy with radiation in women with tumors less than 4 centimeters in size. And at 20 years of follow-up, there is no difference in the disease-free survival, the distant disease-free survival, or the overall survival. But in the patients who had radiation after their lumpectomy, there was a significant reduction in the risk of local recurrence compared with those who just had a lumpectomy. So at this point, the least necessary surgery for patients with smaller tumors became the lumpectomy with axillary lymph node dissection, followed by radiation. And we're going to do a quick aside. So with a lumpectomy, to remove the cancer, the goal is to remove all the cancer with a rim of normal tissue around it to ensure that the whole tumor has been removed. So current guidelines, and these guidelines did not get published until the 2010s, but for invasive cancer, the goal is to have no ink on tumor. So ink means the very border of the specimen that's removed. So it doesn't matter how wide a rim of normal tissue is between the tumor and the edge of the specimen. It just means the tumor cannot come up to the edge. And the same is true for DCIS associated with invasive carcinoma. But for DCIS alone or for DCIS with microinvasion, the margins are recommended to be at least 2 millimeters. And this is because with DCIS, there tends to be skip lesions and becoming less frequent as you go out. And there's a lower risk of recurrence if you get those 2 millimeter margins. So after decreasing breast surgery, the next step became to decrease axillary surgery. This was going from the axillary lymph node dissection to the sentinel node biopsy. So the sentinel node biopsy is the procedure of removing the first lymph node or group of nodes that drain a cancer. And the theory is, since they will go to certain lymph nodes first, that if those nodes are negative, it's a really good indication that there's not cancer beyond those nodes. And the techniques for doing sentinel node biopsy for breast cancer were developed in the early 1990s. And there were two surgeons working almost simultaneously. There was Armando Giuliano at John Wayne out in Santa Monica, who used the blue dye technique. And there was David Craig at the University of Vermont, who used radio-labeled colloids like technetium. And today people tend to use a combination of the two or just the technetium alone. And the first step was to determine the feasibility and the accuracy of the sentinel node biopsy. And how this was done is they had patients get the experimental treatment of the sentinel node biopsy, but then do a completion axillary lymph node dissection. The identification rate in a study published in the late 90s showed that it was approximately 93%. I would argue that the identification rate is now much higher as surgeons are much more familiar with the procedure. The accuracy was about 97%, meaning predicting what was in the rest of the axilla. Did the sentinel node biopsy adequately predict that? And the false negative rate, meaning the risk of having a negative sentinel node, but positive lymph nodes elsewhere in the axilla, was approximately 11%. And looking at a larger meta-analysis of the false negative rate of a sentinel node biopsy, taking into account a couple hundred studies looking at sentinel node biopsy followed by axillary lymph node dissection, if the average false negative rate is around 7%, but if you use a dye and tracer technique, that risk, the false negative rate is as low as 6%. So following this came a study to prove that if the sentinel node was negative, you didn't need to go on to have a completion axillary lymph node dissection, that stopping at the sentinel node biopsy wouldn't compromise the cancer outcomes. And this was a study done in the late 90s and early 2000s, though sentinel node biopsy was widely adopted before that. And before those results were published, just due to the accuracy of it. But in this study, there was no difference in the disease-free survival or the overall survival at 8 years, whether a patient just does sentinel node biopsy or an axillary lymph node dissection with negative sentinel nodes. So the next step was to compare sentinel node biopsy versus axillary lymph node dissection for patients who had positive sentinel nodes. Because following the B32 study, the standard of care was, if the sentinel node was negative, to stop doing any additional surgery after the sentinel node biopsy. But if it was positive, to go ahead and do the completion axillary lymph node dissection, because there could always be residual axillary disease. So studies started looking at eliminating axillary lymph node dissection for patients with positive sentinel nodes. And the main one done in the US was the ICASOG Z11 study. And this took patients with smaller tumors, less than 5 centimeters, who were clinically node negative, meaning when you got your physical exam in the doctor's office, they couldn't feel any lymph nodes. These were patients that were getting lumpectomy with planned radiation after their surgery, meaning the axilla would be treated with radiation as well. And they also tended to get systemic therapy. So, and this compared women with sentinel nodes, 1 or 2 positive sentinel nodes, and they either got a completion dissection or not. And the interesting thing here was there was no difference in survival or risk of recurrence at 10 years out. And this was despite the fact that the patients who had that completion axillary lymph node dissection, that 30% of them had additional axillary disease. So they had additional positive lymph nodes. And so that follows that the patients who didn't have that axillary lymph node dissection also had that extra disease present. But despite this, there was no difference in the risk of recurrence. And that sort of told us that radiation might be good enough to cover that small residual disease. A similar study comparing axillary lymph node dissection and axillary radiation for patients who had 1 to 2 positive sentinel nodes and small tumors was the Emerald study done in Europe. And this one was a little different from the Z11 study because this also included patients who were undergoing mastectomy. And the primary outcome of this study was there wasn't a higher axillary recurrence rate in the patients who had axillary radiation compared to the axillary lymph node dissection. And there was no significant difference in disease-free survival or overall survival. But most importantly to patients' quality of life moving forward was that at 5 years, there was significantly less lymphedema in the axillary radiation group than the patients in the lymph node dissection group. So really the importance of limiting axillary surgery is it limits the morbidity to the patient. So the risk of lymphedema with sentinel node biopsy alone is only about 5%, but with axillary lymph node dissection, that risk goes up to 20 to 30%. And a common question that I get asked in the office is, what about leaving disease behind? Shouldn't we do more surgery? Well, as we talked about earlier, in Z11, 30% of the patients with sentinel node biopsy alone probably had residual axillary disease, but the radiation that they received probably treated this disease because there was no difference in the outcomes and risk of recurrence. So despite finding that we can decrease surgery for a lot of patients with small tumors and no palpable lymph nodes, there are still patients that we should consider mastectomy in. And these are patients with larger tumors in comparison to their breast size. Those with inflammatory breast cancer as a side is an absolute indication for mastectomy. There's patients who had previous radiation to the affected breast should consider mastectomy, but they're starting to rethink that. There's patients with multicentric disease, meaning disease in 1 or 2 quadrants of the breast, or in 2 different quadrants of the breast, sorry. And those with connective tissue disorders, because that means that radiation would cause too much toxicity to the breast and would not be tolerated well. But as I said a little bit before, there's starting to be some workarounds to these traditional contraindications to lumpectomy. So first off, we're going to talk about the tumor size. So, and the objectives of lumpectomy is to remove the tumor with a rim of normal tissue around it. But we also want to leave the patient with a cosmetically acceptable outcome. Now, patients will say to me, not infrequently, I don't care what my breast looks like at the end of this, I just want the cancer gone. But breast cancer is becoming more and more survivable. So 5 years down the road, the same patients who might have told me they don't care what they look like after the cancer is gone, may start caring what their breast looks like. So with larger tumor sizes, it's harder to give patients a cosmetically acceptable breast. But there are ways around this. So there's oncoplastic surgery and there's neoadjuvant chemotherapy. So for oncoplastic surgery, that's where plastic surgery techniques are employed alongside the traditional lumpectomy to leave the patient with a decent looking breast after their surgery with minimal deformities, though it may be smaller, but it also may be perkier. Also, neoadjuvant chemotherapy can help shrink down the size of the tumor. Looking at this graph, it may be hard to read, but the blue and red in the bars show patients who have a good response to chemotherapy, either a complete response or a partial response. And you can see that patients with triple negative and HER2 positive disease tend to have a pretty good response to neoadjuvant chemotherapy and shrink down the tumor or completely eliminate it. Patients with hormone receptor positive, HER2 negative disease tend not to have as a robust of a response to the neoadjuvant chemotherapy. And then following with this, patients who have HER2 positive and triple negative disease are more likely to get that significant response. And therefore, we're more likely to be able to convert these patients to being lumpectomy candidates than those who have hormone receptor positive HER2 negative disease. And as a quick aside, the other benefit about doing neoadjuvant chemotherapy in the HER2 positive and triple negative disease is that we can see what the response was to the chemotherapy, and that can help guide adjuvant therapy recommendations, meaning recommendations for chemo following surgery or immunotherapy following surgery, and those could possibly improve patient outcomes from their cancer. So the other classic contraindication to lumpectomy is multicentric disease. And this is because in studies done in the 1980s and in the early 1990s, there was a higher rate of local regional recurrence for patients who had multicentric or multifocal breast cancer who underwent breast conservation. And this was somewhere between 23 and 40%. But something to keep in mind here is that these studies were done before major improvements in imaging like MRI or tomosynthesis mammogram or better ultrasound. And like even looking at ultrasounds recently from ultrasounds done in the early 2000s, the quality of the imaging is much better. And this was in an era before Herceptin. That only came in 1998. It was before other like therapy options in chemo and endocrine therapy. So some studies recently have looked at the feasibility of doing breast conservation in patients who have more than one site of disease in the breast, either multifocal, meaning in the same quadrant, or multicentric. And in doing like a double lumpectomy procedure instead of taking out the two areas in block as one specimen. And in the study, there were almost 200 patients, and only 14 of these patients did end up needing a mastectomy. But most of the patients, 2/3 of the patients, were able to remove the tumor with acceptable margins in one surgery, with a few others requiring additional surgeries. And most of the patients either had a good or excellent cosmetic result, and this was with the patient rating their result. So this shows us that we can do breast conservation in patients with multifocal or multicentric disease. Other barriers to doing lumpectomy is radiation. So there's two main groups that we're starting to overcome these radiation barriers. So the first is older patients, and like their barrier may be like getting to radiation, where they have to go once a day, 5 days a week for 3 to 4 weeks. And that might be difficult. They may have difficulty getting up on the bed. And because of earlier studies that showed that you really need the radiation after the lumpectomy to make the risk of local recurrence similar to mastectomy, these patients might have been more likely to get a mastectomy in the past. And also previously radiated patients is a traditional contraindication to lumpectomy, because the same thing, radiation is generally recommended after lumpectomy, and a second course of radiation may cause too much toxicity, meaning fibrosis of the breast. So in the past, we've always recommended that mastectomy if there's a recurrence and they had radiation before. So looking at eliminating radiation in women over the age of 70, there was a study done in Canada in the 90s and early 2000, and it showed that radiation did not improve survival for patients with hormone receptor positive tumors that were less than 2 centimeters in size with no palpable nodes, and the patient went on to have endocrine therapy. In that study, 10% of the women without radiation had a local recurrence at 10 years, and 2% with radiation had a local recurrence at 10 years. And that may seem like a huge difference, like radiation decreases the risk of local recurrence from 10% to 2%. But if you flip the numbers around, 90% of the women who did not have radiation also did not have a recurrence. And 90% is still an A. And then a second study looking at eliminating radiation in older patients was done in the UK, and it looked at patients 65 and over. How this study differs slightly from the other study, the KELGB 9343 study, was that tumors could be a little larger, up to 3 centimeters in size, but these patients all did have sentinel node biopsies, and those sentinel nodes had to be negative, and they also had to go on endocrine therapy like the other study. But similar findings. There was no difference in breast-specific or overall survival at 10 years. And again, the patients with radiation had a lower risk of local recurrence than the patients who did not have radiation, but still, there was a good chance either way that there was not going to be a recurrence at 10 years. The other classic contraindication to reirradiation is that they've had it before. And therefore, mastectomy has been the standard of care for the breast cancer recurrence in the same breast. But partial breast radiation is emerging as a viable alternative to whole breast radiation. And there was a small study, around 60 to 70 patients in it, done in the 2010s, that looked after partial breast radiation after a second lumpectomy for a recurrence in the same breast, when they've had whole breast radiation in the past. And at 5 years out, only about 5% had an in-breast recurrence. Only about 10% of patients needed a mastectomy, and the overall and disease-free survival was 95%. And only 7% of the patients had grade 3 adverse events, meaning significant toxicity, significant cosmetic deformity, and none had grade 4 events, and those are like the life-threatening adverse events. And none of the patients had those. And again, despite all our workarounds, there are still patients that mastectomy should definitely be considered as our main recommendation. It is bilateral mastectomy, meaning removing both breasts for unilateral cancer, should be considered for women at high risk of a second primary. And these are patients with high risk genetic mutations such as BRCA1 or BRCA2 or TP53 or PELB2 now as well, because they have extremely high risk. They're more likely to get a second cancer either in the same breast or in the other breast by the time they turn 85 than not. Or patients who've had previous mantle radiation, usually before the age of 30. Patients should definitely be recommended unilateral mastectomy if they have inflammatory breast cancer. Inflammatory breast cancer is when at least a third of the skin is also involved with cancer. Or if they have a contraindication to radiation, and this is really your connective tissue disorders like your scleroderma. There are patient factors associated with choosing bilateral mastectomy, and it's always acceptable for patients to choose bilateral mastectomy, even if they have no genetic predisposition and a small cancer. But it doesn't always improve their outcomes. And reasons patients cite for choosing to go forward with that double mastectomy is desire for peace of mind. It might be for their breast cancer risk perception. They might think they have a much higher risk of a recurrence or of a contralateral cancer than they actually do. And they might want to avoid that contralateral breast cancer, even though they're at a much higher risk of a recurrence from their known cancer. These patients tend to have a higher generalized anxiety. They tend to be younger, or they will cite a desire for symmetry. And looking at anxiety after breast cancer surgery in women who are under the age of 40. So patients who undergo bilateral mastectomy tend to have a higher anxiety level at baseline than patients who underwent unilateral mastectomy or lumpectomy. And while their anxiety levels drop with time after surgery, it still is higher than patients who only had a unilateral mastectomy or breast conservation up to 5 years out from their diagnosis. So to me, the take-home messages here is you shouldn't always use surgery to treat anxiety. There are possibly better ways to manage anxiety. There are things to keep in mind when choosing that bilateral mastectomy. So one, for average risk women, the risk of a contralateral breast cancer is about 2 to 6% in 10 years out from their initial cancer diagnosis. That bilateral mastectomy will not improve the cure rate of the known cancer. It will not reduce the risk of recurrence of the known cancer. It will not reduce the need for chemotherapy or endocrine therapy. It does not completely eliminate the risk of a contralateral cancer. And despite doing a mastectomy, you cannot remove every single breast cancer, or not every single breast tissue cell. So there's always a small residual risk. It reduces the risk of a contralateral cancer by approximately 94%. Doing a bilateral mastectomy compared to a unilateral mastectomy doubles the risk of complications. And in theory, complications that have to be managed could delay the next step in treatment, which could possibly impact outcomes. There usually is permanent numbness of the chest wall following the bilateral mastectomy. And while reconstruction is offered, it's usually not a one-step process, and multiple surgeries are usually involved. So now moving into what surgeries can be omitted altogether at this time. And one of those surgeries that there are times can be omitted is the sentinel node biopsy. And this can be omitted in some elderly patients with breast cancer safely. It can be omitted in patients with DCIS with suspicion of invasion on core needle biopsy receiving lumpectomy. And there are ways to omit it for patients with DCIS who are receiving mastectomy, but this is not available in all parts of the country and at all centers. So first off, elderly patients. So we're going back to that study we talked about before, the CALGB 9343 study. That's main goal was to compare radiation or no radiation in women over the age of 70 who had tumors smaller than 2 centimeters in size that were hormone receptor positive, who went on to have endocrine therapy, who had clinically negative, meaning no palpable axillary lymph nodes on exam. So in this study, 2/3 of the patients had no axillary surgery. The other third had an axillary lymph node dissection. And no matter if they had axillary surgery or no axillary surgery or radiation or no radiation, there was no difference in survival. And for patients without axillary surgery, there were no axillary recurrence at 10 years in the patients who had radiation. And only 2% of the patients in the group that had endocrine therapy alone without radiation. So based on this, a choosing wisely guideline has been, do not routinely use sentinel node biopsy in clinically node negative women over the age of 70 with early stage hormone receptor positive, HER2 negative invasive breast cancer, because it does not improve cancer outcomes. All it does is give these patients a risk of lymphedema. And if you don't have the surgery, you don't get the risk of lymphedema with it. So another setting where sentinel node biopsy has been recommended is for patients who have a core biopsy and the pathologist writes suspicion of microinvasion. So they can't clearly tell if there's microinvasion there or not. So this is just a small study looking at the risk of a positive node in this scenario, and the patients with suspected microinvasion, only about 1% of them had a positive sentinel node. And this is similar to patients who would get a sentinel node biopsy for DCIS alone. If they had definite microinvasion on their core needle biopsy, then the risk of a positive sentinel node goes up to about 6%. And therefore, sentinel node biopsy is recommended for patients with definite microinvasion. But it's important to know, like, if you're having breast conservation, meaning lumpectomy, and it's suspected microinvasion, or even if you're having a lumpectomy just for DCIS, there's always the risk of finding invasive disease that might require you to go back and have a sentinel node biopsy. And you do have that ability with doing a lumpectomy. And some may ask, well, why shouldn't I just do it up front, get it done in one go? But again, if you don't have a sentinel node biopsy, you don't have the accompanying risk of lymphedema, which is a lifelong risk. So DCIS patients, even though there's no invasive disease, if they receive a mastectomy, sentinel node biopsy has traditionally been recommended due to the risk of finding invasive disease. And with the mastectomy, it's not really feasible to go back and do a sentinel node biopsy afterward if there is invasive disease with traditional tracer techniques, because those tracers only persist for not long, like maybe a day at most with some of the radioactive tracers. And by the time you know if there's invasive disease or not, it's too late to go back, and you can't re-inject because the pathways, the lymphatic pathways went with the breast. So the upfront sentinel node biopsy is recommended with traditional tracers. However, there is a new substance, the superparamagnetic iron oxide, or the magtrace, even though we're not really supposed to use trade names. Delayed sentinel node biopsy is possible. This substance remains in the sentinel nodes for at least 30 days after injection. So you do the mastectomy for DCIS, you find that there is invasive disease. In this scenario, you can go back and do the sentinel node biopsy. Unfortunately, we do not have this material at St. Peter's right now. And then despite all of this, there are still patients who still need that full axillary lymph node dissection. And that's for patients with gross matted axillary disease, patients that have a contraindication to radiation with a positive node. Of note, this could be as simple as they've had reconstruction after their mastectomy, they had a single positive lymph node on their sentinel node biopsy. Radiation can have bad cosmetic effects on the reconstruction, and the patient elects to undergo an axillary lymph node dissection instead of the radiation, which could compromise their cosmetic outcomes. Or they've had axillary radiation in the past and they can't have it again, or they have the scleroderma and the toxicity is high. Also with inflammatory breast cancer, axillary lymph node dissection is recommended. And that's because oftentimes after the initial treatment, so the first step in treatment for inflammatory breast cancer is chemotherapy, neoadjuvant chemotherapy. You do not take these patients directly to surgery. Their lymphatics were clogged with cancer cells, and the sentinel node does not often map. You usually can't find it, so therefore the axillary lymph node dissection is what's recommended. So some future directions and in ways that breast surgery for cancer is being de-escalated is there's talk of going from lumpectomy to ablation. in certain patients. And this is in practice, it's being studied right now. Some people will elect to do it off trial, especially if they're older and frail. And these are ablating the tumor, like percutaneous ablation techniques, like either through cryoablation or laser or percutaneous microwave or radio frequency, or there's also transcutaneous approaches as well. Another thing is going from lumpectomy to no surgery, which is being studied. There's looking at it, and this is at MD Anderson, they're looking at omitting surgery completely in patients who've had a complete response from neoadjuvant chemotherapy, meaning after the completion of that neoadjuvant therapy, the patient gets an MRI, they get multiple biopsies, all the biopsies come back as benign. They're seeing about doing no surgery whatsoever for those patients. Also, lumpectomy to no surgery in older patients, and these are your sick, frail, 80, 90, 100-year-olds. Their life expectancy is low anyway. They might have a low-grade hormone receptor positive tumor that's HER2 negative, and it is considered acceptable in a lot of cases to just put them on endocrine therapy and observe, and only proceed to surgery if there's progression of the tumor. And that progression usually takes about 2 years to happen and only happens in about 20% of patients. Also in DCIS. So DCIS is considered a precursor to invasive cancer, but it's a non-obligate precursor to cancer. So not all DCIS progresses to invasive cancer, and DCIS by itself doesn't have the ability to kill you. That's just invasive cancer. So they are looking at what patients can avoid surgery for DCIS, and there's several studies open to that. There's looking at decreasing axillary surgeries as well. So standard of care for patients with residual disease after neoadjuvant chemotherapy currently is to do an axillary lymph node dissection if their sentinel nodes are positive. But again, there's a study looking at comparing no additional surgery to with radiation to completion axillary lymph node dissection. And there's also comparing sentinel node biopsy to no surgery in women of any age with small tumors whose lymph nodes appear normal on ultrasound, who are getting radiation. So that is all I have for you today. Thank you for listening to my talk, and I'm happy to take any questions.
Okay, it's Eileen back again. Dr. Pesek, that was really, really good. Gave us a lot to think about, and some, I think what you did was really helpful to take us through from some of the very early days of breast cancer surgery and give us some perspective that we continue to learn from what has transpired in the past. So, and can use it to predict a little bit towards the future. And so right now, I don't see any questions yet, but I would imagine there probably are a few. And we'll just give that a moment here as things potentially come up. And now I do have one. Okay, so this question comes from Chris Kaufman. How frequently do seromas develop at post-lumpectomy?
So I can't give you a great answer for that, but that's always a risk of surgery of any type, not limited to the breast even. You can get those after abdominal surgery. And they can happen after lumpectomy or mastectomy. That's why you have drains after mastectomy, because there's such a high risk of that. Sorry, I'm talking around this a little bit because I don't have the exact number. But I can tell you from experience, patients who are older and and or obese or have kidney disease or underlying heart conditions tend to have a higher risk of seroma than somebody who's young, healthy, and thin.
Thank you. You know, one of the points that you made, Dr. Pesek, is that for so many individuals that have been treated actively for breast cancer, perhaps they made a decision on surgery, and then in a few years, as their treatment course has, you know, that 5 years out or something, they have a change of heart potentially, or become a little more concerned about, let's say, the look and feel. Are there options for some of those patients in as they are 5 years out? And I think Rita also commented that, you know, the landscape for surgery is different today than it was, you know, perhaps 8, 10, 20 years ago, of course.
So there's a number of like options surgically. So one, if we're like just thinking of cosmetics of it all, and say you have a patient had a lumpectomy, and the one breast is much smaller than the other, there's always the consideration of sending that patient to a plastic surgeon for a symmetrization procedure. If there's a larger defect from the lumpectomy, it could be consideration of fat grafting. To fill that defect again, that's to plastic surgery. And then there's some patients where they try their hardest like to combat their anxiety of disease, and they just can't. They started with a unilateral mastectomy. It's always acceptable to go back and remove the other breast as well. There's also patients who might not have had genetic testing or limited genetic testing with their initial surgery. Genetic testing has improved greatly and is now accessible to a lot more patients than it was before, since like the costs have gone down and the guidelines have expanded who should get the genetic testing. So some patients who might have previously been treated with lumpectomy find that they have a PELB2 mutation, for example. And that's a reason to consider bilateral mastectomy. If they don't have to have it. They can do increased screening with mammogram and MRI every year, but you can always go back and do that more aggressive surgery with the bilateral mastectomy. And one thing I tell patients to keep in mind is you can always go from a lumpectomy to a mastectomy later, but you can't go from a mastectomy to a lumpectomy.
That's, I'm sure that's completely true. So my next question would be along the lines of the legislation that was just passed that, and actually this got quite a bit of fanfare. This was shortly before the election, where there are certain mandates now, an expanded mandate for people who, from insurance companies to cover certain procedures. Do you want to comment on that, or how, if that may change at all, what people are hearing from their surgeons?
So I'm trying to think of which one that would be. So if we go back on the history of all of that, so in 1998, there was a law passed that if an insurance company covers mastectomy, they also have to cover reconstruction. There's a more recent New York mandate that passed, and I have trouble understanding why, to be quite frank, is to cover any techniques. So say a patient doesn't get reconstruction after mastectomy, that they can have a, aesthetically flat closure. And I have trouble with understanding it, because really that should be the goal of all simple mastectomies, is to leave the patient's chest wall as nice looking as possible. So a lot of surgeons were just trying to do that, self-included, and not billing for it. And there's really not great codes to do it. You just change your incision a little bit. So sorry for the confusion, but
yeah, and you know, I the way it was explained to me, and of course I am not a I'm not a legal scholar in any way, shape, or form, but that there were some situations where women had perhaps extra tissue that had been preserved during the initial surgery, with the idea that perhaps they would consider having reconstruction later, and that tissue would be available to them. And then not having the then making the firm decision that no, I don't want to do that. So then
right, okay. So I have strong feelings on this one. I'm going to admit this. It's kind of paternalistic of the surgeon to assume that a patient is going to change their mind on reconstruction, and leaving that quote unquote extra tissue behind really doesn't help the plastic surgeon in the setting of delayed reconstruction, because there's things like tissue expanders that can be placed. They can do flap reconstruction and keep the skin over it to reconstruct it. So really, people shouldn't be leaving that extra skin, because a lot of the time the patient doesn't go back, and then they're left with all this extra tissue there. Before this law passed, I did not have a problem getting that covered on the occasion that I would go back and do revisions of the scar.
Good, thank you. Makes sense. Now I just, so I'm going to now go, Dr. Pesek, to a question that just came in. Okay, so from the speaker, I just had mastectomy following 3 lumpectomies. SNLB, which is I think
sentinel lymph node biopsy,
showed 1 lymph node out of 2 lymph nodes. Her VEER positive VE. I'm going to have auxiliary. I might not be getting all of this right. Auxiliary right, and then we'll go on to 5 years hormone suppression treatment. Your webinar has reassured me for not needing a ALND and AL. I don't know what that stands for.
I'm seeing if I can see some of this just to help out.
You might need to do that, or I can.
Positive out of 2 lymph nodes. I am HER2 negative, ER positive. I don't know. I am going to have axillary radiation. Yeah, she does not need axillary lymph node surgery and radiation for the Amorose study. The morbidity of doing radiation is much less than doing the axillary lymph node dissection. She doesn't need the nodal dissection.
Perfect. Thank you very much for the interpretation.
Especially if she did not have neoadjuvant chemotherapy.
Okay, good. All right, another question. Can you talk more about when you would delay surgery and use a wait and see approach for a patient that has been diagnosed with a DCIS? And you did address this to a certain extent, but
yeah, so that is still completely under study right now. And this really, unless like there's a scenario that I have done it in, is I had a patient with extensive DCIS come in, and there was always the plan to do surgery, but she just had a heart attack. She just had stents placed, and she could not come off her Plavix, her blood thinner. So surgery was risky. So in that scenario, and sometimes it's not just do nothing for the DCIS, it's doing, so if that DCIS is hormone receptor positive, putting the patient on the endocrine therapy, like the anti-hormone therapy like tamoxifen or anastrozole, and then getting them to the point where they can have the surgery safely. So those are the ones where there's definitely consideration of doing it. The other time where we were delaying was early pandemic, and I hope that we're going to get some good information out of it, of delaying surgery and just putting patients on endocrine therapy, especially in New York City. If you came in with DCIS, which is stage 0, and it was hormone receptor positive, you went on endocrine therapy and until a point that the surgery could be performed, because they were so completely overwhelmed with COVID then. And it was, so it's made me somewhat more comfortable, like, we can't do surgery right away. Let's just do endocrine therapy. Let's temporize it and move on. But the study is looking at not doing surgery unless they see progression on imaging.
And I think, Dr. Pesek, you also commented that, you know, from a DCIS standpoint, that unless it progresses, you know.
Right. Or that's for the older patients.
Oh, I see.
Who have invasive like hormone receptor positive disease, like, and you're on dialysis, someone on dialysis, or I saw a 100-year-old woman the other day, like chances are something else is going to kill them before the cancer.
And wouldn't it be in many cases also true that that the disease would be less likely to accelerate quickly?
Yeah.
Okay. All right, well then let's check here. We got a couple of attaboys here, and very good. All right, and so I think that might end the questions for now. And so I do not have any additional ones to add into the mix. I appreciate you addressing, from a standpoint of what's legislated. I think, Dr. Pesek, what you're saying is that you're staying the course. You're doing what you think is the right thing for the patients, and I appreciate you being able to give forthright information and giving us a sense of keeping ahead of what's happening and transpiring from some of the data and the things that we're learning as we go forward. And people do continue to be diagnosed with breast cancer, so we appreciate your service. I will talk a little bit about, there's a number of people, actually there's 2 people that joined us today that have addresses from the UK. And so we have a truly international audience today. So thank you very much. And some new people who I don't recognize as names familiar to 2 Life. And so I'm going to speak a little bit about this particular series that we're doing now, which is our Women's Health Conference series, which is designed to take topics that might not necessarily be just specific to breast cancer, but to take the topic and address it to a breast cancer audience so that you can see the nuance and explain some things that are not necessarily just headline specific, and give people a general appreciation for the topic in this day and forward. And so we will have we'll have several, I got to get my dates here. And so we've got several more programs that are coming up on November. The next one is November 29th. We will have a talk on research and the latest developments and what research is showing us and how that will eventually go into the standard of care with Douglas Conklin, who is an associate professor with the University of Albany and their School of Public Health and their Cancer Research Center. And so Dr. Conklin has spoken for us before, and he always has something fascinating to talk about. But for those who have not been familiar with 2 Life, our website is www.tolife.org. You can see more about some of our information. We have a number of support groups. I know some people are on from our groups, from our support group program, as well as some other programs coming up, and I would encourage you to go there. You can also go back to the website to register for the program with Dr. Conklin and the other presenters that are coming up, including Dr. Heather Stahora, who is with Capital Cardiology, and she's going to talk about the subspecialty of cardio-oncology. That will happen on Tuesday, December 13th. And then going into January, and I don't even want to think about the fact that of how many more days there are to the end of 2022, but we will have Dr. Sandra Shin, and Dr. Shin is the professor and chair of the Department of Pathology and Laboratory Medicine for Albany Medical Center. And so Dr. Shin is very widely known throughout the pathology community and has spoken internationally, and is a wonderful guide and resource in the area of pathology and understanding the pathology, what is going on in your report, and will shed some light in that regard. And so that's going to take place on Tuesday, January 10th. And so I want to say to everyone, I think we're going to end our program, and thank you very much for attending. You will get a rather short survey. It's only a few questions, and we would appreciate your feedback, as well as any thoughts you might have about topics that you'd like to see addressed in future talks. And so with that, I will say thank you to Dr. Pesek and Rita, I'm glad you could join us today. And Chris, who's operating behind the scenes doing our technology. Thank you, thank you, thank you. And for all of you, have a wonderful day. If there's any other questions, you can send them in and we'll send them back over to Dr. Pesek. But this program will be recorded and uploaded to our YouTube page as soon as we can get through the editing. So with that, have a wonderful day. Thank you. Bye.